Good morning. This is J. Greg Johnson, Division Director for Gynecology. Today I'm going to talk about male and female sterilization. Sterilization is the most frequently used method of fertility control in the United States. All sterilization methods prevent the union of the sperm and egg by mechanical blockage. They should all be considered permanent, although some can be reversed. The patient should go into the procedure with the idea that this is a permanent procedure. For male sterilization, the currently used procedure is a vasectomy. This is occlusion of the vas deferens done by either excision and ligation. Electrocautery can be done by mechanical or chemical means. It is an outpatient procedure, can be done in office. There are minor postoperative complications including bleeding, hematoma, acute and chronic pain, and local skin infection. There are no long-term side effects. Failure rate is about 1%, usually due to early intercourse prior to ensuring that live sperm have been cleared from the male tract. Female sterilization can be done in several ways. It can be done at any time except during pregnancy. It can be done postpartum. Or as an interval procedure after pregnancy. In the postpartum situation, a mini laparotomy is done usually at the umbilicus or slightly below, just over the top of the uterine fundus, and is usually done by the Pomeroy technique. So with the patient, supine in the operating room, incision is made in the umbilicus or over the uterine fundus. The fallopian tube is then grasped in the isthmic portion, brought up through the incision, ligated twice, and the ensuing knuckle of tube is then cut, allowing the ends to retract in opposite directions. Risks include bleeding, infection, and accidentally removing the round ligament, which of course would not render the patient sterile. To avoid this complication, the fimbria of the fallopian tube should be visually inspected prior to ligation and placement of your sutures and your incision. Interval sterilization is most commonly done by laparoscopy. But can also be done by a colpotomy incision transvaginally. In doing the colpotomy incision, you usually use the Pomeroy technique as previously described, or do a fimbrioplasty, removing the distal portion of the fallopian tube. You can also do a mini laparotomy low in the abdomen and use similar techniques. Laparoscopy can be done in most situations except with severe abdominal or pelvic adhesions. Electrocautery is the most common method used. One can use either unipolar or bipolar cautery. Unipolar carries the risk of arcing and causing bowel burns from sparking. Bipolar cautery is a safer technique where the current travels down one arm of the instrument through the tissue which is grasped between the two arms of the instrument and passes back up the other arm and is safely discharged through the bipolar instrument. This eliminates the risk of sparking and arcing of the current to bowel, bladder, or other areas where one does not want to coagulate. So when using bipolar cautery, we coagulate the fallopian tube two to 3 centimeters from the cornu of the uterus, and cauterize for approximately 3 centimeters in contiguous areas. An ammeter is used to determine when the desiccation has completely passed through the area of fallopian tube in the grasper. So the bipolar instrument grasps the fallopian tube, coagulating that section, and then in a contiguous area we repeat the process until approximately 3 centimeters of the fallopian tube has been burned. Other laparoscopic methods include the Hulka clip, which is a plastic clip which is held in place by a metal clasp. It destroys less tube than electrocautery, but also has a higher failure rate. The fallope ring involves a silicone band which is placed around a knuckle of the isthmic portion of the tube. So much like the Pomeroy technique, the fallope ring instrument grasps the tube, pulls up a knuckle, and then places the silicone band around that portion of the tube. Problems with the fallope ring include more postoperative pain because the tissue in the knuckle will necrose, thus creating a tissue reaction and pain. Bleeding can occur if one pulls too much on the fallopian tube, tearing the mesosalpinx. Another instrument that is used is the Filshie clip. It has a larger diameter than the Hulka clip and has been shown to have a lower failure rate than these other two methods. So the Filshie clip is applied once again in the isthmic portion. It has a plastic clip which hooks around the fallopian tube, and then again a metal catch is placed so that it causes the clip to occlude and thus compresses the fallopian tube. A newer method of sterilization involves a hysteroscopic approach. With an instrument that is called the Essure. The advantages are it requires no or little anesthesia, usually only a paracervical block is used. There are very few risks. One does have to avoid perforation and be aware that there is a potential for an allergic reaction to the insert, which is made of a nickel stainless steel alloy. The insert is then covered with PET fibers. PET stands for something I can't pronounce, but a long name for a synthetic fiber similar to Dacron or one of the other synthetic fibers. And these PET fibers cause an intense tissue reaction with inflammation, thus causing the fallopian tube to produce scar tissue around the insert and occlude. The failure rate is very low, particularly since we do a hysterosalpingogram at 3 months after the procedure to confirm tubal occlusion. Approximately 95% of the Essure procedures will demonstrate occlusion at 3 months, and properly placed, this goes to 100% at 6 months. Failures occur because of improper placement, or tubal perforation. Complications of sterilization in general are very low. It has proven to be a very safe procedure. Mortality is from 1 to 4 per 100,000 procedures, a very low rate, and these are United States statistics. Mortality and morbidity come from wound infections, hematomas, perforation of the uterus, and laceration of the uterus, bladder, or bowel. These complications occur anywhere from 0.4 to 1%. Major complications are related to general anesthesia, or sepsis, which usually is a result of thermal injury while using electrocautery, or unrecognized hemorrhage which can lead to death. An additional complication is that there is an increased risk of ectopic pregnancy after any of the sterilization procedures, resulting in a rate of 7.3 per 1,000 procedures over 10 years. Still a very low rate. And all these complications occur infrequently and are certainly less than the risks of that are incurred during pregnancy. Failures are related to incomplete resection of the tube, spontaneous reanastomosis, fistula formation, or improper device placement. Failure rate per procedure are very low. The following are rates over 10 years per 1,000 procedures. For bipolar cautery, the rate is approximately 24.8 per 1,000 procedures. The fallope ring is 17.7. The Hulka clip is 36.5. The Filshie clip is 17. Postpartum tubal is 7.5. And an interval mini lap tubal is 20.1. This compares to vasectomy, which is 10. So when taken on a year-by-year basis, all these procedures have a very high effectiveness rate with very few complications. So in summary, male sterilization is done by vasectomy. It is a safe outpatient procedure. Female sterilization can be done in several methods. Postpartum with a Pomeroy tubal ligation. As an interval, one can do a mini laparotomy Pomeroy tubal ligation, or more commonly use the laparoscope and use bipolar cautery, Filshie clips, Hulka clips, or fallope rings to occlude the tubes. Hysteroscopically, the Essure has proven very effective, easy to perform in an outpatient basis with very little or no anesthesia. Thank you.